Hello, good evening. How are you guys today? This is Dr. Radialis from the Georgia office. First of all, I hope that your week is going great. It's usually when we have a holiday, it's kind of a strange week, so it goes a little faster. Today, I always start, normally I always start with a case or a subject that might be of interest that has been presented in the last few days in the clinic. And today I really want to touch on something that unfortunately might be very close to everybody's heart or close to a lot of people's hearts. And it's when things don't go as planned or when things do not go as expected. Today I had to give kind of bad news to two patients, and it was very difficult. And I know that it's difficult on both ends. It's difficult to give the news, and it is very difficult, you guys, to receive the news. So one of my older patients, she is a beautiful 45-year-old, and she had a natural spontaneous pregnancy after 4 IVFs. And last week, her betas were doing great. It was a very early pregnancy. Betas were doing great. Progesterone was doing great. And unfortunately, today I had to let her know that her human chorionic um, hormone levels were dropping, so her betas were dropping, and the ultrasound today showed an empty sac. Um, so she is unfortunately having a miscarriage. And I know that that is the situation for a lot of you. And my heart goes out to all of you, whatever stage in pregnancy that has happened. Um, so even though that is not necessarily good news, and it was very devastating because we were all super excited for her. She's been our patient for 2 years, and prior to that she was in a different clinic for another 2 years, so this has been quite of a journey for her. And this was her first spontaneous pregnancy, so we were all super excited, especially when the betas were going up last week. But after first of all, we have to honor the grieving process. All of us, not only you as you're going through it, because you have a loss. You have a loss of the potential of a life, right? You have a loss of a lot of times of a whole child, just because, like her and some of you, as the pregnancy progresses at the very beginning and things seem to be going great, you are creating in your mind the what if and what's next. And when you see the child running and you're in the baseball game or in the dance recital, you've seen it all. Like, you have a whole life and a whole bunch of expectations on that pregnancy. So when you realize that that pregnancy is gone, it's a loss. It's almost like having a death, right? Somebody died, because the illusion of that child and all that you had going on in your mind, it's gone, like just like when somebody dies. So we have to honor the process of grieving, and you have to be kind to yourself. And us, we try. I know that some healthcare professionals are going to do it better than others, but we honestly do try to honor that process. But in the midst of all of that, all right, I want to remind you that as long as there's life, there is hope, okay? And that the fact that you've had a pregnancy, in the case of my friend, it was a spontaneous pregnancy at 45, which is like, super amazing, super exciting. Um, but it means that she's that much closer to the dream. She's that much closer. So I want to put this out there because I see happy endings, and I love sharing those. But I think also that we need to share the obstacles and the bumps on the road and the stories that might not be as exciting, okay? The stories that sometimes we suffer in silence, um, because they are as honorable and they are a victory in the making. All right, it's a blessing in disguise. So I do want all of you that are going through something like that to think about it. The fact that you got pregnant, the fact that you had a biochemical, that is that one step closer. Okay, that means your body's trying, your body implanted. Okay, in the case of my patient, she has been trying to get pregnant for 6 years, first on her own, she did the whole thing, the on her own, the IUIs, and now she was getting ready to do her 10th IVF. 10. All right, with all the transfers in between, and she started doing PGT testing, and so her journey has been a long one. And then, for her to suddenly get pregnant in between cycles, it's a sign. It's I was definitely super excited, and I was like, yes, we got the miracle baby, the poster child. But again, it's a sign that she's that much closer, and that is a sign for you too. All right. The other case that I'm going to mention, and there might be somebody out there with a similar scenario. We had a patient who had 4 previous C-sections, and I'm not quite sure if this was diagnosed before or not. Apparently, she refused to do a saline ultrasound prior to her transfer. So she had 4 C-sections and a tubal ligation, normal AMH, husband's okay, new partner. And she's 34, 35, I think, mid 30s. And she refused to do a saline prior to the transfer. And so she went to the first transfer failed, okay? And then the second transfer, and, against really medical advice, but she really wanted to transfer too. And because her first transfer failed, she got approved by the transferring physician to transfer 2 embryos, and they both implanted. Okay. So she follows up in our clinic. So we have been seeing the development of the pregnancy. As the pregnancy started evolving and growing, the embryos, one of them is okay. It's they're both alive. There's heartbeats. She's 10 weeks pregnant now. But one of the babies actually implanted in the C-section scar. And what we realized, and that's why it's so important to go through the workup before you actually go through all these fertility treatments, what we realized is that her C-section scar was really thinned out, okay? And then the baby, you can see the baby like just stuck in the muscle. And so the reason I'm sharing this is that it's very scary. I don't really think that she understands the repercussions of one carrying twins with such a thin C-section scar and having one of the babies in the C-section scar. She's at risk of spontaneous uterine rupture, placental abnormalities, meaning the placenta can go through and get into her bladder, and that's like she could lose her uterus, her life, and the babies. And so I got a phone call because now she's pregnant with twins at 10 weeks. So she's trying to find. She went back to her obstetrician, to her regular doctor, who called me and looked at the images. We sent the records over, looked at the images, looked at the reports, and now they're going to refuse taking care of her. So the doctor called me and asked for details on the whole thing, and I said yes. I mean, there is one of the embryos. It's one of the fetus at this point is implanted in that, C-section defect. The muscle is usually thin, seem very thick, but when you have a C-section that didn't heal right, it looks like this. There's actually a hole and a very thin area, and that's exactly where the baby implanted. The group that she normally goes to is going to refuse care. They're going to transfer her out. So that's like that's a very funky scenario for her and for whoever's going to take care of her, because she's a super, super high risk pregnancy. I mean, I pray for her. I hope that she makes it, and that she makes it to a place where those babies survived, because it would be kind of devastating to go through all of that and maybe, potentially be on bed rest and having to go through she's going to have to go through an early C-section, because it'll be way too dangerous to let her go past probably like 32, 34 weeks if she makes it to that point. And from the doctor's standpoint, he was thinking of sending her to the university hospital or the public hospital, because they don't feel that they want to handle that level of complication. So when we go through this, I know that some of you are thinking, why do I need to do a saline ultrasound? Why do I need to do a hysterosalpingogram? Why does my husband need to do a semen analysis? Why so much blood work? It's because we want to pick up those issues before they become a problem. So in her case, she refused the saline, and a regular ultrasound, regular pelvic ultrasound is not going to show something like that. You have to kind of inflate the uterus to be able to see that defect. So it could have been repaired prior to the transfer, and now it's like, she's a disaster waiting to happen. So I wanted to share those scenarios because unfortunately sometimes life is full of twists and turns that we don't expect. And I'm sure there might be somebody out there or multiple people out there that this might be beneficial. Okay. All right. So let me see if you have questions, either this or, complicated things. I had another patient reach out where she transferred 3 embryos, but she has low reserve, and I want to say she's 46, and she's trying to use her own eggs, and she had a retrieval 8 eggs and then 3 day 3s that she transferred, and they did not stick. She does have donor eggs backup, but she still wants to try one more time before she kind of crosses the bridge of like just going into her donor egg embryos. But in her case, she has multiple fibroids that she has been trying to avoid to take out, and it might be time to address that. I know that that's also a discussion: is when to intervene, when is an intervention good for you versus not so good for you. And it's, in this world, medicine is not an exact science. There's a lot of art, and then there is a lot of intuition. Okay. So I have a question here. I'm 40 years old. I want to do an insemination, an IUI with donor sperm. And I'm worried that because I'm 40, I have no chance. So 40s, it's a very interesting age group. Okay. There's a lot of 40-year-olds having babies, more than people realize. I know that, when I was back in medical school, if you were 42 and beyond, they would send you straight to donor eggs and say your eggs are no good, but that varies. That it's a real, you have to, after 40, you really have to evaluate case by case, because my 45-year-old, her AMH at 45 is 1.6. That's pretty damn good for a 46-year-old. So not because you're 40, that means that you have no chance. And then the other thing is I like to hyperstimulate 40 pluses because it gives you a higher chance of success without increasing multiples. Because after 40, our eggs, they're just more frail, okay? So you don't necessarily, everybody assumes that they're abnormal. No, I mean, there will be a higher chance of having abnormal eggs, but you still are making normal eggs. They're just more frail, okay? So sometimes it's better to keep them inside the body and then go through insemination with like a mini IVF protocol where you have maybe 3-4 potential eggs to fertilize, but then keep them inside the body. Now, because you're doing donor sperm, that makes it a little bit more complicated, just because you don't have an unlimited source of sperm. So in your case, it would be nice to be able to see the entire scenario and see whether it might be more cost effective to you to do IVF. So, just if you want to reach out to me directly, you can message me through Messenger. I'm pretty easy to find. And name, phone number, and we'll get you on the schedule, and we can definitely go through your particular case after we evaluate your chart. Thoughts on PGTA testing versus fresh transfer when you're 40? There are many ways of skinning the cat. This is a conversation I actually had with my 45-year-old patient. I am not a big advocate on PGT testing after 40. Actually, I'm not a big advocate of PGT testing at all. There's a lot of data showing that the biopsy itself could mess up the embryo, and a normal embryo does not guarantee a pregnancy. Actually, that was part of the experience of the patient that I was describing earlier. Her first 2 IVF cycles with a different clinic, she did PGT testing and did have genetically tested embryos, and none of them implanted. So I am all about day 3 transfers after you're 40. But if you're like freaking out, you can always do a fresh and then let the other ones grow if there's enough. Part of the challenge that when you're past 40 is that you don't make a lot of embryos. So by pushing them to day 5 and beyond, you might lose them. And so you might end up with like 1 or be completely empty-handed. So me as a woman, that would freak me out to lose my embryos because every egg is so precious. But it's a very personal decision. I would love you regardless. Okay. Hi, Stephanie. This is how I found my defect. Yes, with the saline. It's a big issue, which people don't realize how big of an issue is. I had it repaired in June and still having same symptoms. My doctor won't do another repair. Does anyone see how to do these repairs? It already caused 1 miscarriage. I mean, I've done those repairs, not very commonly, but I have. If you had it repaired in June, it would be great to be able to evaluate the cavity and see how the repair healed. Okay. Do you all transfer abnormal embryos? Our current clinic won't. We have 2. Yes, we do. We do transfer abnormal embryos. Not all abnormal embryos are actually really abnormal. There's a lot of issues with mosaic, and sometimes those like mosaic embryos actually give beautiful babies, and we do transfer abnormals. I had this discussion earlier with that lady that I was briefly telling you about with the fibroids. She has old embryos at a different clinic that won't transfer. She actually has 10 frozen embryos that are probably about 3 years old, and they're all abnormal because her normal embryos did not implant. So she's going to transfer them over. And it's so funny. I looked at her report, and they actually graded the embryos and had the PGT test. and we talked about grading a few weeks ago, and it's like they're all like 5AA, 5AB, and then genetically abnormal. So it's like this is also crazy, crazy stuff. So remember that there is divine intervention. You have to. No, you're not going to be able to control this perfectly. It just doesn't happen. And the more you try to control it, the less it happens. And that's what I've seen in this world. It's like there's a little bit of, yes, you want to be diligent, but at the same time, you have to kind of let it go and let God. Okay. What is your recommendation on functional cysts generating estrogen that you need to quiet them down? Either that or, depending on your scenario and whether you are past 40, your AMH, can you tolerate a little bit of suppression? Either suppress or have like one or two ovulatory cycles, even if you have to trigger just to kind of get rid of it. What can be done for the MTHFR gene? Is Lovenox the only solution? So with the MTHFR gene mutation, there's two genes, okay? More than half of the population is at least heterozygous, meaning they carry one of the abnormal genes. Depending on how many you have, that I could answer that question. Lovenox is not the only solution. If you only have like one gene, you could do aspirin. And the most important thing is the folate, okay, which is the active form of folic acid, because you do not absorb it very well. And the MTHFR gene mutation is associated with neural tube defects and cleft lip and palate. So we use Lovenox a lot more because a lot of our fertility patients are older or they have multiple issues. And so we want to cover any diagnosed or undiagnosed coagulation disorders. Okay. Alrighty, so yes, so Eugenia, so she is sharing a story that she had 5 embryos, but was recommended to push to blast, and she lost 5 of her embryos. I don't have a perfect answer for you. I would have stopped at day 3 and freeze them. Your embryos. Um, the least they're outside of your body is actually the best. And so, how can you not have this happen again? Don't push them, just don't push them. You had 10 embryos at day 3 and you lost 5, and I am sorry. It's terrible, but eggs are not meant to be outside your body. And the older you are, they're more frail. So, one thing is inside of you and the incubator is not the same thing. So, Miss Taylor, what happens in the first consultation with you all? It's a phone call. The doctor or the nurse practitioner, it's going to go through like your medical history and stuff. Depending on the amount of information, I always recommend that people are like ready. The more information I have on you when I talk to you, the more further along in the process that we can be, and we can do management and figure things out. But if I have like zip, then we have to start by sending orders so you can get testing and so forth. Yeah. So yes, Alina, yes. From this angle, I see a lot of you, and I just don't see the benefit to PGT testing. I just don't see it. I see a lot of women that end up, you have to be ready for the answer before you make the question. And I know a lot of you are super excited. You want to find those perfect embryos and get rid of the ones that aren't normal. What do you do when they tell you they're either mosaic or abnormal? And if you're stuck in a clinic that is not going to transfer abnormals, then you can't transfer anything. And so you have 5, 10 embryos and with none to transfer. It's kind of a weird, uncomfortable place to be in. Then what you do with it. So, and again, a normal embryo does not guarantee a pregnancy. I see it all the time. In my book, in my way of thinking, I believe that there's really two reasons to test an embryo. One, you're doing family balancing. You have 5 boys and you want a girl. Okay. You have 5 girls, you want a boy. So I get that. I get that. But you have to have a lot of eggs to get rid of. Okay. So somebody with low reserve trying to do family balancing, just buy donor eggs. It's not going to happen. I mean, I'm just being truthful. If you're 30 or 28 and you want to do family balancing, sure, because you're going to make 25 eggs, and out of those, you're going to find X amount of normal the gender that you want, right? The second scenario would be known genetic mutations. So that would be PGTN. All right, that means that you have cystic fibrosis, or your husband, or there's like a genetic issue that is worth testing. But if you're just trying to test to check if the embryos are normal, I don't agree with. I don't think it's. If I were to do it, I wouldn't do it. I would just do the 3 fresh transfers and save the other ones. Or if I'm older, do some embryo banking. Get them in, and then transfer day 3s. Okay. So, Miss Creasy, so it looks like your case, we might have to work with your PCOS. What I've seen with PCOS patients is that sometimes they make a lot of eggs, but they're not good quality. They're immature, or even like empty follicles. I had a retrieval a few weeks ago where there were 17 follicles, and we extracted everything that we can. And so at the end, she ended up with 3 eggs. So we have to work on the endocrinological disorder, and I have great experience with PCOS and PRP. Actually, my first PRP baby was a PCOS baby. So you really want to, we should probably, I don't think that you need donor eggs. I think that we still need to tweak you. Okay, we need to tweak you to get you to a place where your body functions as perfectly as possible, and then go through the process. And I would not test. I just would not test. I would just transfer. So what vitamins do I suggest for FET? I am very much into whole food vitamins. So, for example, I like glandular therapy, or food-based supplements. So I usually recommend on my consults to get a particular prenatal. I mean, I use Nutritional Frontiers, but Garden of Life is another one that I feel comfortable with. I recommend something called a female endocrine pack, which is glandular based. Okay, so it has little bits of pituitary, adrenal, hypothalamus, ovary. It has a food-based multivitamin and omega-3. I also suggest something called eutrophin, which is also glandular based to support the uterus. Something called Cataplex E. They're all weird names. Food-based vitamin E, because it's an antioxidant and it helps with the function, the functionality of the glands. Vitamin D, everybody's deficient in vitamin D. PRP, That's kind of what I put my patients on. And depending on what's going on, we might do an endoscratch PRP with antibiotics to make sure that we're not dealing with chronic endometritis. And if there are issues or any concern for adenomyosis or endometriosis, then I will make sure that they do embryo banking. So meaning you have 10, 12 embryos ready, or as many as you can possibly have ready. Then do 1 to 2 months of suppression with Orlisa or Lupron with add-back therapy. A lot of doctors don't do the add-back therapy, and it's kind of cruel. Norethindrone, it cuts down like the menopausal symptoms, and then do serial PRP. All right. Okay. So failed transfer, and she's gained 25 pounds and hair thinning. Yes. Unfortunately, there is absolutely nothing normal about IVF. I mean, we really mess up with your endocrine system. Um, I have ways to help you. We just need to kind of level out things a little bit, even do PRP to your hair. We need to work with your adrenal glands. The adrenal glands are the ones that handle stress, no matter which type. And IVF is stress. It is not only emotional stress. Everybody thinks about stress like it's emotional, mental, psychological. But no, stress is also the insults in our body. So surgeries, procedures, this crazy amount of injections that we do, all of that is a stress to the body. And the adrenals perceive stress, and it doesn't distinguish whether it's psychological or physical. So just send me a message, and we can definitely talk about your case a little bit more. In terms of, I know that Letitia, going back to the transfers and the abnormals, the reality is that if you just had your grading, right, which is very subjective, you have, beautiful embryos, and suddenly now you have this piece of information. What do you do with it? The reality is that the majority of the abnormal embryos simply either don't implant or biochemical. The risk of having I mean, first of all, you have the results. Like, there's very few genetic abnormalities that are compatible with life, like trisomy 21, 18, etc. And you have it in the report. So, in the report, it's a biopsy of the area that could be placenta, and a lot of times the embryo self-corrects. Okay, so either it survives the genetic issue or it doesn't. The early pregnancy, it's either a black and white thing. So it's not as scary to transfer abnormal embryos as most people think. I know that most clinics are not going to do it because they don't want to take the risk. And I do honor and respect Dr. Kills for having the guts to let you transfer your abnormals. I mean, we have babies come out of abnormals. That's the reality. All right. All right, people. Oh my goodness. I've definitely talked a lot today, more than I usually do, and I appreciate all of you joining me for our discussion tonight. I want to invite you. We're having an event in Atlanta, October 7. Check it out in Eventbrite. It's called the V Celebration because there is a victory inside all of you. It'll be a time to share the victories that are already materialized, but also share the victories that are not yet in the 3D world. All right. And just the fact that we are breathing, it is a miracle and a victory in itself. Okay. So October 7, it'll be a lunch. Dr. Keels will be there as well. Eventbrite, check it out. And I shall see you soon. I'll see you next Wednesday at the same time. All right. Bye-bye.